The thing is, if you put a really predictable implant into the interbody space, you can now do it through minimal invasive techniques, an MIS A-lift or an O-lift or an X-lift. Just tiny incisions where you don't hurt the normal tissue, and you just put this in, and it's very powerful. In the old days with scoliosis, we had to do all these osteotomies. And one of the challenging operations with a high complication rate is a pedicle subtraction osteotomy, where you have to create all this lordosis. Well, if you go in for the front and you create the lordosis through a cage device with minimally invasive technique, you can correct a curve without the big osteotomy and then just put screws in percutaneously with navigation or a robot. That's a huge improvement in the old days. So you're talking about hardly any blood loss, the risk to the nerves is minimal, and no soft tissue damage to normal tissues. And it's because we have these very powerful implants that we can put in the disc space.
One of the things that you said struck a chord with me relative to the design of the cage, and that is you said, if I'm not mistaken, that you put in a bigger implant that's broader because of the architecture and allowing you to put bone in it the way you do. You're not putting a small cage in and surrounding it with bone. It sounds like you're actually putting which gives you a greater footprint, which then should lead to a less incidence of subsidence. And then you add to it that snowshoe design that kind of just intuitively makes sense that would reduce the incidence of subsidence.
Absolutely. It's really unusual to get subsidence in a four-web cage.